Thank you, everybody. Thank you for being here online. Thank you for being in person. And again, my name is Stuart Schlossman. I'm president and founder of MS Views and News. And this is an MS Views and News Compass to MS Care, Rural America and Beyond program. And as you can see, we're supported by EMD Serono, Genentech, Novartis, Sanofi, and TG Therapeutics. And let's give them a round of applause, please, because we want to thank them for being our sponsors of this series and making sure that we're able to bring MS educational programs to people that are in need of learning more about multiple sclerosis. Next, we have Dr. William Kilgo. He's the chief at the University of South Alabama, also serving as the Neurology Residency Program Director. After earning his MD and completing his neurology residency at USA, he pursued fellowship training in multiple sclerosis and neuroimmunology at the University of Alabama in Birmingham. His professional focus centers on delivering comprehensive care to people living with multiple sclerosis and related disorders, enriching MS neuroimmunology, education for trainees, and helping reform public policy for access to high-quality MS care. Let's give a round of applause to Dr. Kilgo and welcome him on the stage.
All right. Can you all hear me? Okay. Thanks to everybody for coming out. As Stuart said, I'm William Kilgo. I'm a neurologist here in Mobile at the University of South Alabama. Really glad to be here today and talk to you a little bit about multiple sclerosis. I won't claim to be able to cover exercise and its benefits in the same detail as Jeff there, but I was listening just as intently as you were. So we'll get started. I can't see the PowerPoint on the screen. That would help me because there we go. So some disclosures. These are some companies I work with. I've done some clinical trial work and I'm on a speaker bureau. And I'm hitting the button, the big green button. There we go. So most of you are here or watching online. You know what MS is, but it's an immune-mediated disease. It affects something called myelin. Myelin is like the rubber coating around your nerves. It's essentially like the rubber coating around wiring, for electrical circuitry. So, it carries those signals from your brain down into your spinal cord and arms and legs. And damage to myelin from inflammation leads to disruption of those nerve signals. And many of you have experienced those symptoms. It can be cognitive symptoms. It can be poor balance. It can be loss of vision, double vision, a number of things. And we diagnose MS by, using our diagnostic criteria. And for someone to have MS, they need to have, more than one piece of evidence of damage to their nervous system separated in space and time. And we'll talk about what that means. I'm not very good at PowerPoint, and I got excited one day and made this animation, and I'm very proud of it. So I've included it on my presentations. But, think of your brain sending this signal down the myelin sheath, and it's not disrupted. These little yellow things you see on there, those are what we call, the myelin sheath, and it has little interruptions in that called the nodes of Ranvier. And those nodes are spaced at different intervals. And when you have damage to myelin, you lose some of that protection. So that signal is essentially disrupted and doesn't quite bounce out like that, but it doesn't travel as quickly. So good example I give people is trying to charge your phone with a phone charger that is not in the best shape. It gets hot, it still charges your phone, but it takes a lot longer. So it's essentially a failure of energy to conduct efficiently. And that's essentially what we're having with symptoms of MS. So who gets MS? According to some, recent estimates by the National MS Society, we're getting close to a million people in the United States. That's what we think based on claims data. Women have a prevalence of about 3 to 1 compared to men. That's in relapsing MS. If you look at primary progressive MS, it's about equal, 1 to 1. Young adults are most commonly diagnosed with MS, but it also affects, people of all ages. There's some evidence that it's more common the greater the distance from the equator, where you grew up and went through puberty. And it affects all races and ethnicities. It's kind of, out there that it's a disease of Northern European white women. But, anybody who, sees patients with MS, we see it in men, we see it in women, we see it in Caucasians, non-Caucasians. So the incidence of it is it's not just one group of people that gets it. I think that's important to recognize because that at least a health disparity, at least a delayed diagnosis in the non-classical population. So, anybody can get it. So there are different classifications of MS. They've come out with these different subtypes. It's all one disease, but thinking of relapsing MS and non-relapsing is kind of the way we've evolved. So if you think about relapsing types of MS, these are people who have, lesions on their MRI that are changing over time. They have relapses clinically. So we have clinically isolated syndrome, which is someone who has their first clinical attack of MS. Maybe they don't quite meet the diagnostic criteria for MS immediately, but it's still considered a subtype of MS. Then we have your classical relapsing remitting, someone who's had more than one relapse or clinical attack or clear evidence of it going on over time. And then we call active secondary progressive. So people who are still having MRI activity, still having relapses maybe, but they're having progression of symptoms between attacks. So that's just a, more nuanced way of talking about it. Primary progressive MS is patients who maybe have a slow creeping disability to start with. It's not really recognized early. They may just have some difficulty walking that progresses over a couple of years. They start as I'm tripping, and then I have foot drop, and then I can't do my activities anymore. And, those patients are a little harder to diagnose just because they don't have some, big impressive loss of vision, like over a day. It's more of a over years process. So often retrospectively diagnosed in a lot of cases. And then we have what we call non-active secondary progressive MS. Essentially patients who've had a relapsing course of MS, they're no longer having relapses, they're no longer having MRI activity, but they're getting worse. So those are just the different ways we talk about it from studying it in a clinical trial point of view primarily, but it's all one big disease, okay? So another thing we're going to start talking about is some barriers to accurate diagnosis and then access to the most effective treatments. So one thing I see a lot with patients in my clinic is it takes them a long time to get to me. One, maybe not even necessarily to be diagnosed, but a long time to get to a specialist. We've had these FDA-approved treatments for MS for over 30 years at this point. Back in the 90s, certain classes of treatments came out, and a lot of neurologists are very comfortable with certain types of treatment and may not be as comfortable with the newest therapies. So very often they're maybe sometimes what might be considered outdated practice patterns still adhered to by some people. Wait till the patient is in bad shape before you come see the MS specialist, or they failed multiple treatments. So we're going to talk a little bit about that. So just in terms of, access to care, one of the main things we see around here is delayed diagnosis. One of the main things that drives outcomes in MS is time to treatment. So time from symptom onset to when you're treated. A lot of people believe there's an early window in which we can make a big difference in the lives of patients of MS. That early period in diagnosis when we're having multiple relapses, we're having a lot of the inflammatory change that goes on. Shutting that down early, we think leaves it to better outcomes. And you can see in this chart, it's orange for no treatment, green for intervention at diagnosis, gray for later treatment. But, essentially patients who are treated earlier, tend to do better. So there may be different reasons like lack of expertise, overlooked symptoms, attributing it to something that may seem more likely. different practice patterns among different people. So there are a lot of different things that can lead to a delay in diagnosis. And different approaches to treatment. So we'll talk about this a little bit. We have about 30 different disease-modifying drugs now. We're lucky to have different classifications of treatment from, introductory or, low efficacy treatments to more high efficacy treatments, and we'll talk about that. So in terms of delayed diagnosis, looking at registries in the US, the average time to diagnosis from first being brought to attention is about 1 year, essentially. We did a study over this summer, kind of looking at my patient population, and we found that the time from onset to diagnosis was about 2.2 years around here. So it takes about twice as long around here to get diagnosed for one reason or another. And then we looked at things like time from diagnosis to treatment initiation, 1.1 years. So that's not time to diagnosis, that's time to being treated. So that's a long time. So what we're finding is, patients around here are diagnosed later than average and they're undertreated. So in terms of, real world rates of misdiagnosis, there's been some studies around the country looking at patients referred to an MS clinic with a pre-existing diagnosis of MS. They found about 1 in 5 patients were misdiagnosed. So there's delay in diagnosis, there's misdiagnosis. So we did another kind of similar alongside look at our population. We found that about 16% of our patients, by the time it was all said and done going through the workup, were misdiagnosed. So that has implications for things like proper treatment. And these are some of the things we found. The most common reason someone is misdiagnosed is they have an abnormal MRI and they don't have symptoms to go along with it that are consistent with a diagnosis of MS. So those are just some of the other things we found. But and that has implications. So some of these treatments, they're great. When they're used inappropriately, they can have side effects, though. So we can talk about that. But I was getting into disease-modifying treatments, and MS is one of the few neurologic conditions that's degenerative that we can modify the course of the disease. So we can change someone's outcome with MS. We know that based on natural history studies, which were done before we had any treatments, that about 90% of patients with MS are going to have some sort of walking difficulty after 25 years, and 50% at 10 years. And that was in populations of patients who were untreated. And we know that, I've talked to some, neurologists who've had longer careers so far than me, what the MS clinic used to look like when they would go rotate with it. Patients were all being rolled into clinic. And now, we're seeing differences in how patients are doing. MS is getting more prevalent. We're talking about things like aging healthily with MS now because we've got really good, much better control of it than we used to. So we're going to talk a little bit about this. There's different classes of medications. You can argue over what constitutes introductory versus moderate versus high efficacy. This is kind of how it's thought about among MS specialists. So we're going to talk about these types of drugs as we go, so I won't go into too much detail on this. But so what constitutes high efficacy therapy? How many of you have heard that term before? Or highly effective medicines for MS? So we have about 30 different drugs. We have about 6 or 7 different mechanisms of action. When I say high efficacy, I mean in terms of rates of reduction of relapse, rates and reduction of MRI activity, effectiveness on disability progression. That's what I'm talking about in compared to other drugs, okay? So what we found is that earlier use of high efficacy therapies is increasingly seen as the best strategy or an improving strategy to mitigate long-term disease sequelae or long-term problems from MS. And kind of in spite of that, we're still seeing kind of a pattern among a lot of treating physicians for what we call an escalation pattern, which is where you choose maybe the oldest drug you're most comfortable with that's considered the safest, and then you wait and see how the patient does. So you kind of wait for a relapse and you change therapy, or you wait for an MRI change and you change therapy. So, and that there's really no clinical basis for doing that. It's just kind of the way things have been. And there's no, well, there's not, been clear evidence as to which treatment strategy is the best. That's why we've come up with some clinical trials in recent years to help address this question. One called Treat MS, another called Deliver MS. They're essentially putting patients into two different groups. One, at diagnosis, they're either assigned to the conventional approach to treatment, which is kind of escalation if you need it. And then the other group is randomized to high efficacy therapy early. And those trials are going to be reading out in the next few years. We'll see what they say. But in some of the, clinical trials from, drugs have been in development, they're finding that patients on these high efficacy therapies, if they were in the placebo group or, what we call the active comparator group, those patients, when they're re-randomized or if they go in an extension study and they get on the high efficacy drug, they don't catch up in terms of, disability progression. So they're finding that earlier use of these drugs is associated with better outcomes longer term. So some barriers that are not medical to high efficacy treatment, insurance coverage. How many of you have gotten a letter in the mail that says the drug your doctor said was right for you is not right for you because of your insurance plan, right? So that's really common. We see irrational approaches to this from insurance companies, largely based on reimbursement patterns. They may have something called a pharmacy benefit manager that they contract out to decide what drug's going to be covered, and it's not based on efficacy. It's not based on anything but cost, negotiated cost, actually, because most of these drugs cost about the same. So largely, most of the formularies are based on that because we don't have clear guidelines or clear clinical trial evidence of high efficacy therapy, just in general being better. So that's why they're doing these trials I mentioned to help, give us some guidelines. And there may be an anchored practice pattern of escalation. So maybe physicians who came up 30, 40 years ago are used to a certain way of treating MS, and they're uncomfortable with some of the newer medications because they have perceived safety issues, right? So I would encourage, everyone to have a mindset of proactive approaches to treatment rather than aggressive, because treating more aggressively is treating more effectively. That's the way I think about it. And we can navigate, any of these issues on an individual basis. And by no means are these drugs right for every single patient, but, there are different ways we can mitigate a lot of those concerns. Some of these medications may have what is thought to be a higher burden of monitoring. So laboratory monitoring, MRI monitoring. Well, that patient has all this stuff. I just don't want to deal with it. It's too much paperwork burden on my practice. So we're seeing, some of this is driven by, insurance and all of this. But in my clinic, I see a lot of patients with MS. We have staff, and their only job is to deal with the paperwork. That blows my mind, the amount of time we spend on that. And of course, access to care, is another thing. Just getting referred to a neurologist, sometimes even in Alabama, in rural Alabama especially, is very difficult. There may be under recognition of symptoms by primary care providers or the first physician you see. So it's tough, I know. So getting that awareness out there is something that we're working on. This is another study that was done. They were looking at cohorts of patients who got early use of high efficacy therapy versus later use. I was talking about that catch up. So you see kind of the difference in these two populations over time. That's a citation. A lot of these studies are done in countries with, unified data registries for who got what drug and when, and they may have national policies on how that works. So some of this is referencing countries like Sweden or Denmark who may have these national registries. But when you compare, the patients who got early high efficacy the y-axis or the upward axis is cumulative hazard or risk of progression from MS. You see the patients who got early use of the high efficacy therapy have a less likelihood of progression over many years. So some more evidence there. This is just another chart kind of mimicking that. So, we're kind of discovering over time that early use of these more highly efficacious treatments is associated with better outcomes. So what are some of the options for high efficacy treatment? Most of you probably don't think of these as anti-CD20 drugs, but in your head, but these are some of the drugs you may have heard about in more recent years. This is an increasingly adopted form of treatment. Many patients are being started on what we call anti-CD20 drugs or B-cell therapies, ocrelizumab or Ocrevus, ofatumumab or Kesimpta or ublituximab or Briumvi. These are all drugs that work on something called B cells, and I'll talk a little bit about that in a minute. These are all based off of the development of a drug called rituximab that's been out for a long time, generally developed for, oncology indications, but we found over time that their targets had a really prominent role in an MS. Natalizumab or Tysabri, and another drug called alemtuzumab or Lemtrada. These are all, infused medications for the most part, with the exception of one, cladribine or Mavenclad. It's an oral medication. I'm going to talk about it specifically. So natalizumab or Tysabri, this is an infused medicine. It's given every 4 weeks. It works in a different way than the anti-CD20 drugs or the B-cell depleters. So this is not a cell-depleting drug, but it works on a surface protein in white blood cells that essentially helps tighten the barrier between the blood and the brain. So it kind of keeps, overactive white blood cells from entering the central nervous system and causing inflammation, essentially. This drug has an association with a pretty serious complication called PML, or progressive multifocal leukoencephalopathy. So it has a monitoring program in place that's pretty strict. But the drug has somewhat of a reputation for that. But this drug has patients in whom we know that it's pretty safe. We have patients whom we know it's probably not safe, and that's different for every patient. But in general, the safest patients to receive natalizumab are patients who were early in diagnosis, who were negative for the JC virus antibody test in their blood. There's a clear difference between that population and patients who have a positive antibody test in their blood, have been treated previously with multiple immune suppressants, or have been on the drug for 2 years. So we're talking, orders of magnitude difference in the risk between those two patient populations. So, it's important to, individualize treatment for every patient, but this is a good option. All right, so the B-cell depleting therapies, or the anti-CD20 drugs I was talking about. So B cells are, one of the main types of cells in the circulating immune system. You may hear about B cells and T cells. So B cells produce antibodies. Antibodies are like little signatures or reminders for cells of something they've encountered before. So antibodies communicate between different cells. So B cells produce them. Antibodies sit on the surface of certain cells. Proteins are on the surface. So what this drug does is it targets a surface, or this type of drug targets a surface protein on the surface of B cells called CD20. It's basically hey, I'm a B cell. That's kind of what it says to the rest of the immune system. I'm not going to bore you with most of this, but B cells are thought to have really a key pathogenic role in why MS does what it does. So they found that, B cell depletion is one of our highest effective modes of treatment, just based on recent clinical trials. So a lot of the drugs that are coming out these days are B cell therapies or acting on B cells. Okay. So these are the different B cell therapies that are out. We have ocrelizumab or Ocrevus. It's an intravenous drug given every 6 months. Some unique things about it. It's given as a split dose, or you split the first dose in two, and then it's given as a single dose every 6 months after that. All of these drugs have fairly similar side effect profiles, which is risk of infection in the long term. There's also a new version of Ocrevus called Ocrevus Zenovo. It's essentially a subcutaneous version of it that can be given every 6 months instead. Not a lot of difference otherwise in the profile of the drug. We also have ofatumumab or Kesimpta. It's a subcutaneous, B-cell therapy. It's given once a month. It's advantage for a lot of patients is it's self-administered. Some people really like the idea of that. Some people don't like the idea of that. And any kind of subcutaneous injection, risk of injection site reactions and things like that. And then we have ublituximab or Briumvi. It's another IV every 24-week medication. Its differentiation factor is that it's a 1-hour infusion instead of several hours in some cases. It has some, modifications to, what they call glycoengineering to make the antibody bind more tightly to its target. It's proposed to, maybe not factor into the efficacy, but some of the other factors with the drug. And then we have, very similar risks otherwise. And then, while these aren't FDA approved for MS, we have rituximab and its biosimilars. Some of the advantages of those are from, just cost to the health system, point of view. These drugs are much less expensive because they're more accessible sometimes. But lack of that FDA approval sometimes is also a barrier to their use. But they're given every 6 months. But sometimes there's more flexibility with how you dose these two because there's no really agreed upon dosing protocol for MS because they weren't studied specifically. So the other couple of options, these are called immune reconstitution therapies. So they work a little differently. So the first one we'll talk about is called cladribine or Mavenclad. This is an oral medication. It essentially works on lymphocytes and leads to a depleting effect. And I'm going to have a graphic evidence of this in a minute and show you. It's easier to look at than tell you. But one advantage of a drug like this is it has an overall shorter duration of being immune suppressed. So it's kind of like you get hit once at year 1, you hit again at year 2, and then maybe you're not on treatment for several years after that. There's some things to consider with use of this drug, like monitoring for malignancy over time, family planning with a drug like this. You may only use it for the period in which you're not supposed to, start a family on it is 18 months instead of the whole time you're on treatment. So there's some advantages to it from that point of view. Side effect profile is pretty decent. And, long-term, with the exception of, blood tests, generally a low monitoring burden there. So it's a nice option. Alemtuzumab or Lemtrada, this drug came out a few years ago. This is a once yearly infusion. Again, like Mavenclad or cladribine has a short total duration of treatment. And it has some things to consider with its side effect profile. It's definitely a very effective drug. It works on something called CD52, which is a surface protein in active circulating lymphocytes, and it's a cell depleting drug. So we kind of get a really, you get a pulse of immune suppression with this drug at year 1, and then kind of come back to normal, and then hit again at year 2. And I'll show you kind of what goes into that. There's some side effects to consider with this drug. About a third of patients end up developing hypothyroidism on this medicine. There's some infusion-related side effects that have emerged in recent years, like arterial dissection in some cases. But for the right patient, it's a very good option. The monitoring burden with this drug is a bit higher too, just because of those potential for side effects. So patients are subject to once monthly labs for 5 years at a minimum when they start this drug. So we can talk about some of that. And this is kind of the basic theory. You kind of see 2 points when there's a downward deflection on the blue line, those are patients who were treated with cladribine. So we're kind of looking at lymphocyte counts. So they go down at year 1, down at year 2, then come back. And then there's kind of a longer term surveillance after that. So that's kind of what we're doing with a medication like this. Similar, intent with Lemtrada, total lymphocyte depletion we're looking at here. So we're kind of hitting at year 1 and year 2, or month 1 and month 13. We're seeing those drops in the lymphocyte counts and then returning to normal before retreating. And these drugs have the advantage of, relative treatment freedom for a lot of patients, or, a shorter duration of treatment, but you have to make sure that they're right for each individual patient. So I'm going to talk a little bit about treatments that are emerging. Anyone here heard of BTK inhibitors or Bruton's tyrosine kinase inhibitors? So these are kind of the newest class of drug that are in development, probably coming within the next few months, maybe a year from now, hard to say. This is a promising class of drugs for patients with progressive disease. So we've gotten really good at controlling the relapsing part of MS, or the inflammatory part of it. So relapses, MRI changes, but the patients who are left behind in a lot of these trials are patients with progressive disease. So they're looking at different study targets for these drugs, and I'll talk about that in a minute, but you're going to hear more and more about something called PIRA, or progression independence of relapse activity. So that progression that happens when you're not having a relapse, even though you may be well controlled, not having relapses, not having MRIs, but the disability accumulation that's still coming. So the drugs that are kind of coming, probably the one that's coming soonest is one called tolebrutinib, and another one is called fenebrutinib, and there's many of these that are in development right now. Another drug called frexalimab is in development too. It's an anti-CD40 ligand, and CD40 our ligand is a surface protein on activated T cells, and we find that it's elevated in patients with MS. It's kind of in early phase studies too. So, but promising data in the phase 2. You should see some phase 3 trials with it coming soon. And how many of you have heard of stem cell transplantation for MS? So it's kind of there are different types of stem cell transplantation. There's, your roadside clinics who charge you $30,000. Then there's what's being studied in clinical trials. So there are differences. But, they're looking at autologous hematopoietic stem cell transplants, or HSCT, now in a lot of, there's a couple of trials going on right now. The one that I'm most familiar with is called Beat MS, multiple clinical trial sites around the country. So it's essentially kind of, you give the patient a really potent immune suppressant, and you kind of you grow a population of stem cells from that same patient, and then you put them back in, and it involves very serious commitment. It's a lot like having you go in a transplant unit for a good while after getting a therapy like this. So there's some safety considerations with it, but it's emerging as a highly effective mode of treatment for patients maybe who have failed other therapies. And you're hearing a lot about it, some famous people who have gotten it, and things like that. So we're going to shift gears a little bit. The talk is about aging in MS. I think it's important, to understand that, MS is a disease of the whole lifespan. So it's not just when you're newly diagnosed and put on therapy. You got your whole life ahead of you. So a little bit about advancing age. We're all getting older every day, but there's more and more healthy aging that's occurring with MS. So the prevalence of it is going up, and about 50% of people living with MS are over 50. A lot of our clinical trials are done in people who are 18 to 55 years old. So what do we do? When somebody's over 55, we're all just kind of doing what we want. But, there's some data emerging. We're getting more complex considerations as someone gets older. Aging itself creates some challenges. There's something called immunosenescence, or the immune system kind of changing or getting less firepower as you get older. So some of these drugs that may have more potential for side effects in certain populations. So you hear a lot of talk about de-escalation or even stopping treatment in people who are aging with MS. Comorbidities. So as you get older, you get more likely to develop things like heart disease, stroke, high blood pressure. Some of these things can affect the way we manage you in terms of the risks, particularly maybe findings on an MRI. They can mimic MS sometimes, so those are some things we keep in mind. The majority of patients with MS are women, and women go through menopause, and the hormonal environment changes significantly, and we see changes with that as patients with MS are getting older. And like I was saying, the effects of just chronological age overlap with what we think are signals sometimes for disease worsening and signs of progression. So if someone is this something that's just from the patient being a little older, or is this, multiple sclerosis driven? It's something that we have to consider carefully. This is from a recent paper that was just published in the last, 3 or 4 weeks, actually, looking at, consideration of age and MS. It's a big review article. This is kind of just a graph talking about what I was talking about. They talk about immunosenescence, where, over time, the immune system isn't doing as much as it used to. They also talk about something called inflammaging, which I thought was really interesting. The immune system environment can shift in terms of the different inflammatory mediators that are present or absent in the bloodstream. So the type of inflammation we may be seeing as someone's getting older can change. As the immune system matures, you get different environments of cells circulating too. And there's also, considerations of reproductive aging. So that's just a interesting little chart that I thought was in there. So we also talk about, we hear about MS being diagnosed in younger people, but what about when it's diagnosed in someone who's in their 50s or older? While that's not common, when you do have someone who's maybe presenting for the first time with what you think is a diagnosis of MS, you need to take more care to have an accurate diagnosis. Some of those age-related concerns I talked about, like the effects of what we might call microangiopathic disease or hypertension-mediated high blood pressure changes on the brain can cause your MRI to be abnormal. So very often these patients will pursue further workup, like spinal tap or getting spinal fluid analysis to look for certain markers that support a diagnosis of MS. And very often, if I have someone who comes into my clinic who's in their 50s, MRI looks like MS, but I'm not sure, I'll add on a spinal cord MRI. Even if I'm not sure they had a spinal cord attack. If you have lesions in your spinal cord, you don't get those from high blood pressure. You get them from MS, right? We also have, different imaging and fluid biomarkers that can help be more specific on the diagnosis in this population too. And I'll talk about those in a moment. I alluded to this a minute ago. Most of the clinical trial populations for all of our current treatments for relapsing or remitting MS are usually between 18 to 55 years old. But still, there's widespread use of disease-modifying drugs in people who are over 50. So we kind of wonder, does that mean just because it wasn't studied, should we stop treatment? I don't think that's necessarily the answer for every patient. But as you're getting older, there's a higher potential range of adverse events. Kind of what drug you're on and for how long depends on your health for the most part, and what are your risks. So there are people who are old numerically, and there are people who are old biologically. So I'm more concerned about how biologically old you are than what the number next to your chart says. So we all kind of know people in their 80s who are doing great, running marathons, and we know people who are in their 60s who are frail. So it kind of depends a lot on the individual patient. Comorbid conditions, so being as healthy as you can is like Jeff was saying, exercise and minimizing your risk of things like high blood pressure, heart attack, and stroke are really important. Disability status too. I forgot what's on here, so we're going to find out together. Okay, now I remember. So this is a chart, a good example from that article. They were looking at kind of the typical, disease course of a patient over their lifespan. So maybe in 2010, they were diagnosed with clear lesions on an MRI. They had a low disability score, because they had this relapse. And then they're good for 6 years. They're on a disease-modifying drug called fingolimod or Gilenya. They do well for 6 years and they have a relapse. But at this time, they've developed some comorbidities. So maybe they've had a heart attack. They've developed high blood pressure. They've developed high cholesterol. There's some issues with fingolimod, an ongoing use in patients with cardiac disease. So we might take that patient off of treatment and move to a different mechanism of action. So maybe that patient switched over to ocrelizumab or Ocrevus at that point. They do well. They're age 51 at that point. We get to 2021, they've developed maybe a few more comorbidities. They have COVID-19 infection. Maybe they're put in the hospital. They have pneumonia. They're on ICU. They're on a ventilator for 21 days. So you wonder, is that patient over-immune suppressed potentially? So you keep an eye on them. And then a couple of years later, you see some, laboratory evidence of adverse effects potentially. The patient's not really having relapses anymore. They're having some evidence of, stabilization of their disability score. So you might take a break from treatment at that point, maybe a holiday, whatever you want to call it, coming off of treatment there. But it looks like, maybe in this case, they took some time off. Maybe the patient's having some disability worsening, so they decided to go back on. So, there's different, every patient is different. Every patient's experience is different. So there are a lot of things to think about in terms of why we switch when we do. It has to do with overall health of the patient and their risk of treatment. I think most people know that. So the things I'm kind of alluding, we talk a lot about treatment, but then treatment discontinuation is something we've always wondered about. Everybody's getting older with MS. These drugs, may have potential for side effects. So when should we stop treatment? They did a clinical trial on this. You may be familiar with it. It was called Disco MS. It wasn't about dancing. It was about discontinuing treatment. Okay. So the whole point, use of immune suppressants, even beyond 55 or 65, may have some risks. So clinical trials have attempted to address this question in certain populations. So the one I'm going to reference is called Disco MS. It was looking at stopping in patients in this population who were over 55, had not had a relapse in more than 5 years, had not had MRI lesions in over 3 years, who had been on a DMT or some drug for the last 5 years and were on their current disease-modifying drug for at least 2 years with good compliance. So this is what we call a pragmatic clinical trial design, meaning that it was patient-centered. No pharmaceutical company would dream of doing a study like this because it would be against their financial interest to stop treatment. I'm not saying for our sponsors here they wouldn't do that, but this is a patient-centered outcome based clinical trial, right? So patients were equally randomized to either continue their disease-modifying drug or stop. And what they found, 90% of patients did not have a relapse or an MRI change. Relapses were not common. Out of the 259 patients, there were 4 relapses. One of the 128 patients who was on DMT had a relapse. 3 of the 131 who were off their DMT had a relapse. Only one of those 4 relapses really had any kind of correlation with an MRI new lesion. But when you look at overall disease activity, there were 6 events whether it was an MRI change or a relapse in the continue group. And there were 16 events in the patients who stopped treatment group. So there were 3 relapses and 13 MRI changes in the group of people who stopped treatment. So, we see a bit of a difference in what happened in those 2 groups. Disability progression, though, was similar between those 2 populations, about an 11% risk of it. And if you're continuing treatment, about a 12% risk if you discontinued. And there weren't really any differences in patient-reported outcomes or cognitive status between the 2 groups. But overall, when you get into the statistics, this is what we call a non-inferiority study, meaning was it inferior or was it not inferior? What they found was that it was not non-inferior, which means that it could be inferior, to stop treatment. So it's kind of an unanswered question, but you can look at the numbers and see that in certain patients it might be reasonable, but, still to the point where we don't know. Okay. So my thoughts, this is an individualized decision. You should really make this decision with your neurologist, your MS specialist. I don't proactively take patients off of treatment, but, I know that there are some patients for whom that might be a reasonable decision. Okay. So there's this also evolving definition of progression. I talked about the BTK inhibitors briefly. They have this kind of insidious term they've come up with to describe it called smoldering MS. So like the match with the brain is kind of menacing looking to me. So what is this? So this is that progression of symptoms, progression of disability between patients who are not having relapses or between relapses or disability we don't attribute to a relapse. So this may look different for different patients, but in my clinic, I'm seeing, cognitive complaints, subtle limitations in activity. I can't do this as much as I could, 3 to 5 years ago, but their physical exam is the same. Their MRI hasn't changed. Their disability score hasn't changed, but what they feel and see every day is different. So that's kind of what we're talking about with this. And I talked a little bit about this before, some, imaging biomarkers. This is a busy slide, I apologize, but something called paramagnetic rim lesions that have kind of come into attention in recent years. There's been a lot of talk about this in clinical trials, but these are thought to be, what we call chronically active lesions or slowly enlarging lesions at the periphery on a brain lesion. So these are areas, you see this kind of brown outer edge of this lesion that's thought to be areas where iron deposition due to macrophage activity or inflammatory activity. So that's kind of what we're seeing in terms of biological evidence of this happening. And these are probably going to emerge as something we look at in clinical trials. But when you look at the presence or absence of this type of lesion, they're very specific for MS. So if you see these in someone with an abnormal MRI, the odds are that they probably have MS. So they're they've made it into our diagnostic criteria in an upcoming update. So and that could be theoretically what's being targeted with some of these new drugs. All right, we're gonna reorient ourselves again and talk about symptomatic management of MS. Jeff did a really good job talking about the exercise part of it, so I won't try to undercut anything he said because he knows. So a lot of the things we deal with every day: fatigue, bladder symptoms, spasticity, cognitive issues, anxiety, depression. Sexual dysfunction is under-recognized too. But by far, I think if patients could take away one thing, I think they would take away the fatigue. That's what most people tell me. And every patient, is different. Every patient looks different. No patient has the exact same symptoms or exact same MRI or exact same treatment recommendations. So, It's all individualized, but if you look at the percentages of patients with these complaints, numbness and tingling is up there, walking difficulty, fatigue. So these are what patients may be reported as their most disabling symptom. So there are different ways we manage MS. Disease-modifying drugs and medication are one, but lifestyle, if it's bad for your health, it's bad for MS, is a good way to think about it. We all know smoking is bad. We know that smoking leads to, increased risk of disability, poor outcomes in MS. So not a lot of my patients are smokers anymore, but I make a point to talk about it, when they come in. Obesity, it's kind of a relatively pro-inflammatory state, so we see differences, in outcomes in patients with lots of comorbidities like obesity, and that can be due to inactivity, poor diet, and like Jeff was saying, exercise. Everybody can exercise, but exercise is more challenging for patients with MS, right? Because we have this debilitating fatigue. We may have disability that limits mobility. But it used to be the prevailing theory that exercise worsened MS. And as much as it may, it can cause, you need to reach a point where you're comfortable exercising, like he was saying, reach a point when this hurts or this causes symptoms, that's your sign you need to take a rest. But exercising does not worsen MS, okay? Research actually supports a disease-modifying effect of exercise and improvements in quality of life metrics like fatigue. So there's a lot of evidence to support this. I don't have all of the clinical trials in front of me, but we strongly recommend exercise. Okay. When it comes to diet, like Jeff was saying, there's no one diet that you have to do. Eat what's healthy. Less fast food, less processed food, more meals with just a few ingredients instead of 100 ingredients. Okay. So, but I know that's challenging. The stuff that's cheap is the stuff that's bad for you, and it's easy to get, right? So fatigue, like I said, there's a difference between MS fatigue and other causes of fatigue, right? But MS fatigue is worsened by some of these other things you may have. So insomnia, anxiety, spasticity overnight, pain overnight, urinary frequency, especially if you're getting up 5 times to use the bathroom at night. All of these things affect the quality of your sleep and the way you feel during the day. So very often we'll probe for what we can do to help these other comorbidities if a patient has significant fatigue. But urinary frequency is kind of under-recognized. So, early referral to a urologist if you need to, or try some of the bladder medications. They make a big difference. So there are some pharmacologic or medical options for fatigue. They've done some more studies in recent years. Patient-centered clinical trials have been done. This one was called Triumphant MS. They looked at amantadine, methylphenidate, which is a stimulant, and then modafinil, which is a drug for wakefulness. They found that when you looked at these drugs, they were not superior to placebo. So the medications, didn't do any better than the sugar pill. Some of you may have heard about amantadine. This is a drug that was developed a long time ago. It's not a stimulant, but it has some, different uses in neurologic patients. But it's a non-stimulant option for fatigue. Historically, about a third of patients respond to it. That's kind of what I see. Probably more like 1 in 5 is what I've observed, I would say. The drug with the best data that I've seen is modafinil. This came out of a study that was done recently. They looked at it in combination with something called cognitive behavioral therapy, or working with a psychologist. So they found that treatment with modafinil, with or without cognitive behavioral therapy, improved outcomes. Found that it was similarly effective. The caution with this study was there was no placebo group. So this was kind of like looking at modafinil with and without therapy. So that's the qualifier there. And then, off-label use of other drugs. There's a drug called dalfamperdine that's been out for a long time. It was developed for Gait, primarily in MS, but there's some, subjective and more clinical trial evidence and some studies that have suggested symptomatic benefit for fatigue with it. So I'll often try that. So gait issues or walking issues, it's often multifactorial. So patients with MS have different symptoms. So, they can be musculoskeletal, it can be spasticity, which is a difference in muscle tone. We'll talk about that a little bit, but focal weakness, sensory loss, pain from one cause or another, whether it's, orthopedic or neurologic, and edema or swelling. If someone has a chronic disuse or doesn't use one side of their body, it's going to have swelling, right? So, because the venous return changes over time when you don't use your limbs. In terms of treatment options, I think by far one of the best things to do is exercise and, get as much strength and flexibility as you can. But in terms of medication, we'll often use dalfamperdine for MS-related gait impairment. It was studied and found that when you look at the distance someone walks in 25, the time it takes someone to walk 25 feet, they found an improvement. This drug was a lot harder to access, until more recently when it's gone generic. Necessarily, it's a little easier to get now. And finding a good physical therapist, who has experience with MS, I think is really important. And they can help address individual issues and devices that'll help with your mobility. I think just getting where you want comfortably, I think is important. We talked a little bit about spasticity. So Jeff alluded, this is an imbalance of relaxation and excitation due to damage to your central nervous system. So like anytime you contract a muscle, you unconsciously relax another one, right? So spasticity is an imbalance of that. This can be intermittent, it can be chronic, it can be positional. So you can have a chronic increase in your tone, and you can have superimposed spasms or cramps on top of it, like he was saying. So very often this is worse overnight for a lot of patients. Sitting a certain way, just flexing your leg or straightening it will trigger it for some people. And in terms of managing it, rehab and exercise are incredibly important. You heard all the benefits of that this morning. But removing any triggers you can, if it's a problem with the way you're sitting or the device you're using, if it's someone who uses a wheelchair, maybe making some modifications to the chair with a rehab professional, certain medications, certain procedures, and lifestyle like exercise the best we can. So some of the exercises I talked about, we know exercise makes you healthier, but these are some of the things they may talk to you about: stretching, range of motion, weight-bearing exercise. Casting is something that wasn't mentioned. So maybe someone with kind of a chronically, flexed arm due to immobility. So kind of progressive, casting is kind of emerging as a way to kind of change the baseline tone in some of these patients. And if gravity is the problem, you can reduce gravity by doing pool therapy. So working in the pool is often a good solution, both from lower temperature and better ability to use your arms and legs. And we recommend, I forgot the number he quoted, but 30 minutes a day is kind of what we recommend, moderate intensity exercise per week. And what you can do is the most important. What's fun for you, what gets your heart rate up, what pushes you a little bit more than just your daily activity. And no one's perfect. You can just take one look at me and think I probably don't exercise that much. But we all know, and just starting is the best thing you can do. And when it comes to spasticity, oral muscle relaxants, so you've all probably had experience with some of these. baclofen, tizanidine, dantrolene. These all work in different ways, lowering muscle tone. They can be used as needed, or they can be taken regularly. A lot of them have similar side effects like sleepiness or dizziness. Some of them can cause liver damage. So just important to use them and be monitored if you're going to use them. Benzodiazepines also may have a role. So things like diazepam or Valium or lorazepam or Ativan in some cases can help with central lowering of muscle tone. But those are also controlled substances. They can be habit forming with dose escalation often required. So we're very cautious with those. And all of these things can be used kind of as needed or scheduled. Kind of depends on the patient and their needs. So we increasingly use anti-seizure medicines. Personally, I like to use either carbamazepine or oxcarbazepine. These work on something called ephaptic transmission, or unintended neuronal firing or muscle contractions, kind of due to rewiring of the nervous system as it's being repaired, is a good way to think about it. So maybe turning on the lights in the kitchen and the blender comes on is a good way to think about it. So maybe this may be in the form of something like spasms. So a drug like this may have a preventive effect and lower the frequency or severity of those symptoms for you. I'll usually use these in combination with an oral muscle relaxant too. Botulinum toxin injection or Botox. We use this in combination with these other therapies. It's a toxin. It causes muscle weakness. So we have to be careful where we use it. Advantage of it is it lasts 3 months at a time. That's also a disadvantage if it works way too well because you're weak where they did it. So you kind of have to have a caution with the amount you use. We usually use it for localized or kind of focal spasticity rather than generalized, because it would be a lot if we were injecting you in every muscle group. For more severe cases, there's something called intrathecal baclofen or a baclofen pump. This is essentially a continuous infusion of baclofen directly into the spinal canal. This is for patients who are maybe not responsive to oral medications or could not tolerate them. It involves surgical implant under the skin with a little tube that kind of goes into the space outside your spinal cord. And because this is such a big deal to get this put in, they do a test dose. So if any of you have ever had a spinal tap, it entails getting another one and kind of them doing a test dose of the medication first to see how you respond to it. But for patients with, severe spasticity, a lot of mobility limitations or pain specifically due to their spasticity, these are an increasing thing. One thing to know about these is they require regular refills. So they have to be refilled pretty much on schedule every time. Withdrawal from this can result in things like seizures. So it can be dangerous if they're not refilled appropriately. So you have to have the right patient for this too. Some of the other sensory symptoms, some of you may have had these things. Trigeminal neuralgia, if you haven't had it, there's no good way to describe it, but it's, lancinating or stabbing facial pain, usually on one side. A lot of patients with MS will get this, but not everybody with this has MS is a good way to think about it. This is usually responsive to medications, but sometimes it's not, and it might require surgery. Lermit's sign, buzzing or tingling down your neck into your arms and legs. If you look down, that's a pretty common symptom of MS due to pathology in the spinal cord. And then most of you have probably experienced what they call the MS hug. Feels like being squeezed. It can feel like being choked to some people, but it's a sensory kind of phenomena we see in MS sometimes. And how do we treat those? Trigeminal neuralgia can be treated medically for the largest part, but, in some cases, patients with MS will refer for surgery. Kind of depends on the patient. If they have a vascular cause of trigeminal neuralgia, an artery that's pushing on the nerve, sometimes a surgeon can help decompress that. Lermit sign, very often we'll use some of the neuropathic pain medicines, like I mentioned before. Very similar for the band-like dysesthesia or the MS hug. Okay. Cognitive symptoms, it's not often that patients with MS end up with a dementia, but they very often will have cognitive processing issues. So maybe difficulty multitasking, concentrating, often worsened by heat or fatigue. And there are different ways to go about this, but cognition worsening is a sign of disease worsening. So optimizing your disease modifying drug would be one thing. Sometimes fatigue being under control can cause cognitive complaints. So maybe optimizing control of fatigue, optimization of sleep, and again, addressing any underlying depression or anxiety, because that can often mimic, memory loss to someone with uncontrolled depression or anxiety. Oh, I got to the end. Okay. So just some final thoughts. Early and accurate diagnosis of MS is the most important thing, in my opinion. Highly effective or high efficacy DMTs may have superior benefits when used earlier. We think they do. New therapies are coming out to address progression, like I said. And, aging with MS doesn't always mean we stop your treatment. It might mean we just take different considerations. And symptomatic management of MS. So I'm on a DMT. I'm not having relapses, but I still feel bad. There's something we can always do. And sometimes that's taking away a medication that's causing adverse effects. So that's all I had. Glad to answer questions.
Thank you so very much. That was a very, very nicely laid out presentation. You covered so much. There shouldn't be any questions. I think you spoke about everything to do with MS. So if anything, it's going to be limited. Otherwise, you're just going to get hit with what I have questions for you. But we do have a few questions online. Could somebody from my team let me know if there's anybody in the audience in person that has questions?
When you talked about the misdiagnosed in the beginning, you was talking about, my question is, can you still have lesions when you're being misdiagnosed? I mean,
Yeah.
even though they see the lesions,
Right.
so can you still be saying that
Sure.
that's not MS?
Yeah, I mean, in my opinion, the number one cause of misdiagnosis is someone having an abnormal MRI for a different reason. So sometimes it's due to maybe this person has really uncontrolled high blood pressure, or there are a lot of different reasons, and so a lot of these things are benign and don't cause problems. But that's the number one thing we see is someone getting an MRI that was done for a different reason. They haven't had a typical clinical presentation for MS, and they have these white matter lesions or spots. And why are they there is like the most important thing. Working backwards from an MRI is usually not productive if there are no symptoms, but very often you can uncover, something if you look in the right patient, but it just depends. But yes, you can have an abnormal MRI and not have MS.
You were mentioning the spinal cord MRI. Now, spinal tap, supposedly spinal tap will show chemical for they have MS. Okay. However, if they're not having an acute phase, or if they're not having symptoms, and the spinal tap still says no MS, but how do you what's
Right. Okay.
What's the better way to diagnose?
A spinal tap, we do it very often, not necessarily to confirm someone has MS, but to look for other causes. I think you're referring to when someone has an abnormal spinal tap, something called oligoclonal banding. That's usually present in upwards of 85 to 90% of MS patients, whether they're having an active attack or not. So it's one of our markers. It's not specific for MS either. So we know that there are patients who will not have abnormal spinal fluid, but they also need to kind of more completely fit the diagnostic criteria in other ways. So the CSF is not the only thing, but it's one of the things we use. So she asked, what about MRIs of the spinal cord? We'll do those if I need I like to have a baseline MRI of the brain and spine on every patient. And, we're looking for lesions in different parts of the nervous system, also including the spinal cord.
Do symptom management medications lose efficacy over long-term use?
So do I see medications lose efficacy over time? I mean, I think.
For symptom management,
Oh, okay. Yeah. I mean, every patient's needs change from year to year. I see that, often if someone is having increasing evidence of spasticity or other increasing complaints in spite of what we're doing, I'll make sure that it's, not a relapse causing those symptoms for one. But very often someone will get put on high doses of an oral muscle relaxant early in life and continue it like into their 50s or 60s, and it just stays on their med list, and they may not need it anymore. So sometimes we reduce them. Sometimes we have to go up and down with the dose.
Please address the success rate of neuromodulation interstim for bladder problems in MS patients.
I'm not 100% familiar with the data on the success rate. Neuromodulation, or like what most of you may have heard referred to as a bladder stimulator, is often an option with your urologist. Usually it's someone who's failed multiple oral medications, because it's a surgical implant essentially. And another thing to know about those is make sure that they're compatible with you continuing to have MRIs, because MRIs are something MS patients are no stranger to needing. So just make sure you talk to the physician who wants to put one in about, can I still have my MRIs?
Is spinal tap the only way you can diagnose MS?
So is a spinal tap the only way? No, it's part of our diagnostic criteria, and not every patient needs one. I've diagnosed plenty of patients without one. Sometimes if there's a question of the accuracy of the diagnosis, I might need one, or if I really want to exclude other things, will I do one? But you can meet the clinical definition of MS without a spinal tap, for sure.
I would like to know, does MS leave a long-lasting nerve damage? I used to love to walk, but when I walk now, it's like the nerve wake up in this left leg, and I can't do the walking like I used to. But I keep I went to a meeting once before, and they said I may be still having I think he said an evacuation or something in the knee, could last for 5 years. But I keep waiting on it to leave, and it's just not leaving. It's about to drive me crazy with the nerve pains.
So can there be long-lasting nerve damage?
Did it happen when I took a fall? Or
Right.
what is it coming from? It's
Right.
just this nerve pain
So
that won't go away.
right. And there's a tendency to blame every neurologic symptom patients with MS have on their MS, but also important to make sure it's not a different process, like a peripheral nerve compression at the knee or something like that. So we can do, testing like a nerve conduction test, but multiple sclerosis usually does not affect the peripheral nerves, but it can cause central, neuropathic pain that can mimic peripheral nerve pain. So it can be difficult to tell, and it can do what you're describing. Yes.
Person wants to know if you could explain what microglia is about.
What are microglia about? So they're a type of cell in the brain. There are different types of cells in the central nervous system, and I'm far from a basic science neuroscientist, so I may butcher this, but microglia are involved, in central nervous system function. Inflammation can occur at the level of the microglia. It can occur at the level of the neuron. So there's a neuron, and there's supporting cells, both for neuronal repair and inflammation, and that's essentially what microglia are involved in. And I wasn't thinking much about microglia before I walked in here, but some of the therapies are focusing on what we're calling central, or that smoldering inflammation kind of, we think it's mediated at the level of things like the microglia. That's where some of these new drugs in development are targeting. That's my way of talking around it.
But continuing on that, so that way it could help you go further with this. You're talking about all this time about B cell depleters, but what's being done for the T cells?
So almost all of our drugs in development, in preceding years targeted T cells. So B cells and T cells work together. It used to be thought that the T cell was what was driving MS from an imbalance of, inflammation and anti-inflammation. So a lot of the drugs that came out earlier were called immunomodulators. So they would rebalance to an inflammatory state of less inflammatory versus pro-inflammatory. So that's kind of the T cell theory, but we're finding that I like to think of B cells as agitators of T cells is kind of what I like to think of it.
A person wants to know why she has increased headaches and migraines since being diagnosed with MS.
Well, I don't know this patient's individual circumstance. We do see an increased association or comorbid amount of migraines in patients with MS, but one doesn't necessarily cause the other. But we do see kind of an increased frequency of migraines in patients with MS. So, it's just another thing to worry about. But one doesn't cause the other, but we see an association.
Oh, thank you. Next another person writes, what happened to the biosimilar natalizumab, which was supposed to save on costs?
So there's a new form of natalizumab that's out called Tyruko. It's a biosimilar, meaning that it is the same drug biologically, but manufactured by a different company, and they're able to make it less expensive. I have not used it yet personally. I don't really have significant concerns about biosimilars in general, but generally, if a patient is well controlled on a medicine, I'm not going to switch it. Now, when it comes to new patient starts, I'm not as worried about one or the other. But if I have a patient who's stable on a medicine, especially if that medicine is reversible, like natalizumab or Tysabri, and I'm being told I need to switch, I'll probably advocate for continuing.
So, Dr. Kilgo, the Tyruko was approved in the USA, but it was not ever approved to be marketed because they had been waiting for the JC test
Right.
to work with the biosimilar. So
Right.
I think that's what the person was trying to
Right.
ask why that hasn't happened yet.
Right. And why it hasn't happened yet, I'm not sure. I think a lot of us might have concerns about a drug like that having a different required monitoring system. So I can't speak for why yet, but I do know that drug is, that's probably why I haven't seen it yet for that reason.
Okay, thank you. Going back to Tysabri for a minute, people want to know also about they've been told many times by their doctors that they can never just come off of Tysabri without being put onto something else. Is that the same thing that happens with the other MS medications? Because we do hear that some need washout periods. Why don't they work the same?
So I think stopping Tysabri in particular versus stopping other drugs, what you need to consider is the reversibility of the drug and how quickly that occurs. So particularly maybe someone who's been on Tysabri for a long time, maybe a physician is thinking about stopping it. I think there's so much we don't know. I think if you're going to stop a drug that has a very kind of rapidly reversible way of working like Tysabri, I like to think myself about, putting something else in place. But there always comes a time when you have to come off of a treatment, and how you do that is important. And some of the newer treatments, like the B-cell therapies, they have much longer periods of reversibility over several months instead of weeks. So it's a little bit less of a acute concern if I have someone coming off of like ocrelizumab versus Tysabri. You need to have a plan if you're going to stop Tysabri, is the way I talk about
Okay,
it.
thank you. Thank you. Next question online is, what do you think about BTKs addressing PIRA specifically, and those also addressing disability?
I mean, I think it's promising. They're one of the first drug categories to really try to address that. I think something we need to know is how those drugs perform against the drugs we currently have, because we're seeing those drugs less successful in trials for relapsing or remitting MS. So they've kind of shifted their focus more to patients with progressive MS. So if I have a patient, for example, who's on a B-cell therapy like ocrelizumab, and they're still progressing, how do I know that a BTK inhibitor is going to be any better at that than ocrelizumab? And there is a study in progress looking at another BTK inhibitor versus that. It hasn't resulted yet. So when I see that data, I'll be more confident about what we're doing.
Thank you. That leads to the next question. What do you do with a patient that does not respond to treatments? So suppose a patient may have been on Tysabri, but tested positive for JC antibodies. So the doctor just took the person off, even though they may have been testing very low for JC. They were put onto a B-cell depleter. They don't do well on B-cell depleters. What's next?
So, I mean, I think at every patient's individual risk you need to think about. So if someone, for my personal practice, if someone is stable on Tysabri, they have a negative JC virus antibody test, I'm going to leave them on it. If they have a positive JCV test, it depends how positive it is, because we have data to look at, how positive, goes along with your risk. And you have to also look at especially if you're going to transition that patient to a B-cell depleter, there are different levels of immune suppression to consider. Tysabri has a very specific risk of certain types of infections, but you have kind of a more generalized risk of infection with B-cell depleters to balance there. So switching treatments and why we switch is controversial. I don't at the drop of a hat take someone off Tysabri if they turn JC positive. I talk about different ways we can mitigate that risk. And if it involves switching, we'll do that. But if it involves changing the dosing strategy, maybe we'll do that. So it depends on the patient.
Great, thank you. And by the way, I personally wanted to thank you for the way you listed the different genres of medications at the beginning and showed the types of efficacy is associated with each one as well. I thought that was a dynamite thing to be discussing, which a lot of people just don't hear about when they listen to other conversations. Okay, and the last question that I have is from a person that wants to talk about going to Mexico for stem cell treatment. And his concern that he has spoken with others is that what happens when he comes back? What if he gets sick? How does he get back to Mexico? Or how is his local doctor going to be able to know what was done to him in Mexico?
I think you answered your own question there. The problem with, I don't know what particular clinic we're talking about. The problem is a lot of these places aren't regulated. We don't know where you're going, what you're getting. So there are ways to get stem cell transplantation, in the United States. Some of these places that offer it, I don't know everyone's motivation, but if it costs you tens of thousands of dollars, I would think twice about it.
That will be what we call a wrap. And let's thank Dr. Kilgo for being there today. And that's all we can do for this program, okay? Thank you so much. And again, I want to thank all of our sponsors for this program today. Again, we had the support of EMD Serono, Genentech, Novartis, Sanofi, and TG Therapeutics for helping us make this Compass MS series, Compass MS Care series, last the amount of years that it has, and for the many years that we have going forward with this as well. Everybody, thank you and have a great day. Drive carefully.